my pleasure to introduce the next speaker, Dr. SHEETAL BRAR. She's conducting this IC and the chief instructor. She will be just a short introduction. She did her cornea fellowship from Arvind, and then she did a phaco-refractive fellowship from Netradama, and she has numerous awards to her name. Every film festival she has won, and she has some very nice films and a lot of best papers and over 50 publications. And she will be telling us the story of the epithelium and how important it is. And this is something that a lot of us do not look at, but it is increasingly being talked about for refractive surgery screening now. Over to you, Dr. Sheetal.
Thank you so much, sir, for the kind introduction. So, good morning, everyone. I'll be talking about epithelial thickness profile and how it can be so useful to us as refractive surgeons. So, I'll start with some facts about epithelium. We all know that epithelium is a barrier to the external environment. However, along with the tear film, it also has a very important function as it represents an optical interface that plays a critical role in the refractive power of the eye. So, even small changes in the corneal epithelial thickness can cause significant refractive changes. The power of the refractive epithelium alone ranges from 0.5 to up to 1.85 diopters in the central 2 mm diameter zone. So, this is very significant for a refractive surgeon. So, various studies have evaluated epithelial thickness profile, and this was a paper from Reinstein et al., and they have demonstrated that the epithelial thickness profile is actually non-uniform. So, it's not uniform in all the zones of the cornea. So, the average central epithelial thickness is 54 microns with a standard deviation of 4 to 5 microns. The superior epithelium is slightly thinner compared to the inferior, and the temporal is slightly thinner compared to the nasal. So, superior is thinner because of the blinking action of the lids, and temporal because of the more exposure to the temporal quadrant of the cornea compared to the nasal. So, as a refractive surgeon, we must be very cautious because, as I already said, that epithelium is not a homogeneous layer over the Bowman's membrane. So, if you can see here, this is an advanced ectasia, and over time, how epithelium is covering this ectasia, this surface. So, if you do a topography, it would actually look like a normal. In this area, it will not probably show very ectatic cornea because epithelium is filling this gap so nicely. So, it compensates for stromal surface irregularities. It becomes thicker over valleys and thinner over the hills where the stroma protrudes, as it attempts to minimize abrupt changes in the stromal thickness. So, the anterior cornea may appear smoother on topography compared to underlying stroma, and if you only assess your topography without any knowledge of epithelium, it may be misleading. So, in the current scenario, we have ASOCTs and very high frequency ultrasound such as ARC scan to measure epithelial thickness profile. So, principle of ASOCT, we all know it's spectral domain OCT, and the ARC scan has a 50 to 100 megahertz ultrasound system. OCT is a non-invasive, non-contact method, whereas with the ARC scan, it's an immersion method and needs a special medium and topical anesthetic. OCT is less operator dependence, and ARC scan has a high operator dependence, due to which the repeatability and accuracy can suffer sometimes because of corneal compression or decentered position of the probe. And in the OCT, the tear film is included, whereas in the ARC scan, it is not included. So, out of all the commercially available OCTs which are there for epithelial thickness measurement, the MS39 is the recent one. It does not require a cornea external lens. Its resolution also is the highest, and the area measured is also the widest. It's 16 millimeters compared to the others. So, let's look at the clinical applications of epithelial thickness mapping. So, first and foremost, it's the screening of ectasia risk factor, ectasia risk in refractive candidates. So, as we know that corneal thinning is a hallmark of corneal ectatic diseases, and in histological studies, it has been shown that there would be a localized zone of epithelial thinning over a steep area surrounded by an annulus of thickened epithelium, classically referred to as epithelial donut pattern. So, if you see, this is a moderately advanced case of keratoconus, that's the cone, and This is the epithelial thickness profile. So corresponding to the cone, there is a thin area on the top, basically here, and this is around the cone. You have a thickening of the epithelium in the form of a donut. So this is a typical donut pattern that is seen in ectatic diseases. And here you see a case which is a suspect on topography. Basically, this is a pentacam map of this patient. So there's a little bit of inferior symmetry, asymmetry. And here there is elevation of about 29. Of course, a high elevation of 29 is highly suspicious of keratoconus. You can use epithelial thickness for verifying this as well. So when we do MS39, you can actually see, because this is a OCT that along with the tomography also gives epithelial thickness. You can see corresponding to the area of elevation, there is epithelial thinning here, and around this there is some amount of thickening of the epithelium. So early donut pattern is forming in this case. So epithelial thickness profile can also be used to enhance the specificity and avoid false positive cases. So sometimes on topography it may look like a keratoconus suspect, but if you confirm with epithelial thickness profile, it actually may not be the case. So say in this case, you can see that it's a regular with the rule astigmatism, and it's a slightly thin cornea, 460 microns. The posterior elevation is plus 15, anterior elevation is normal. So here if you see the epithelial thickness profile, it's absolutely normal. In the center there is in fact epithelial thickening and not thinning. So it's a normal epithelial profile. So probably you can observe this patient, or if the patient's refractive error is low, probably you can do a PRK or an extra procedure also. So in dry eye, the epithelial thickness profile is something like this. Overall epithelium becomes thinner, and this is something which is a sensitive parameter for refractive candidates. So planning refractive procedures, specifically for those procedures where epithelium is involved, such as trans-PRK and phototherapeutic keratectomy or the PTK, it's important to have a knowledge of epithelial thickness profile. As we know that there is a variability and there is a differential distribution of epithelial thickness on the cornea, so the nomograms have to consider these observations. So refractive regression, again very very important topic for refractive surgeons. We all know myopic corrections can over time show regression over time, and this is because of the epithelium compensating the flattening in the center. So we published this paper in 2016, which was aimed at evaluating epithelial thickness profile following SMILE for myopia and myopic astigmatism. And what we found was that in low myopia, there was a thickening of about 6.8% at the end of 3 months, in moderate myopia 9.2%, in high myopia as high as 12.7%. So this is so significant, and through this you can actually also differentiate between regression and undercorrection seen in the post-op period. So your treatment plan or how you're going to manage the patient is completely going to be different once you are sure of your diagnosis. Early ectasia versus regression. This is again, of course, an advanced ectasia does not need an epithelial thickness profile to diagnose it. However, there can be cases where the ectasia is really early, and there it can actually help you a lot. So this is a case operated for -9 diopter SMILE, and at 6 months patient was accepting a -1 with 0.75. And on the right side I have a case that was operated for almost 5 diopters, 5.5 diopters of spherical equivalent post SMILE at 3 years. Patient was accepting a similar kind of a refraction, 1 with 0.5. But if you look at the epithelial profile, it is completely different in both the cases. So the first one is actually showing regression due to epithelial thickening in the center, whereas on the right side you see an early donut shape pattern which is forming with a thinning in the apex and a thickening in the mid-periphery. It can also be used to differentiate between myopic and hyperopic ablations. Again, for classical cases, for higher corrections, it is not so important. However, sometimes we get patients for cataract surgery whose refractive surgery was done many years ago, refractive error was low, and the pachymetry and keratometry can actually appear to be very regular. So due to the epithelial hypertrophy that has occurred over time. So in those cases, when you do epithelial thickness profile, it can actually tell you about the type of ablation that was done. So for myopic cases, of course, you will have some amount of thickening in the center, and in hyperopic, it will be a pattern quite similar to keratoconus central thinning with the peripheral, mid-peripheral thickening. So planning enhancements, again, very important, especially if you want to plan enhancement for smile and you want to do a thin flap LASIK. This is very important because if you're not considering epithelial thickness and you want to plan a flap over a cap, you might end up either too superficial or deeper. So it's very important to measure epithelial thickness and accordingly plan so that you do not enter into the epithelium and cause a buttonholing. And you should also have a sufficient clearance from the previous interface. So to conclude, knowledge of epithelial thickness profile is especially beneficial in close call clinical judgments. And the newer modalities combining epithelial profile with stromal elevation maps enable a more confident decision making by ruling out false positive cases of suspect keratoconus before refractive surgery, and are thus very helpful to a refractive surgeon. Thank you so much for your kind attention.